So good morning. I would be taking a lecture today on diagnosis of inborn errors of immunity. The topic provided to me was diagnosis of inborn errors of immunity, but I have slightly modified it to diagnosis inborn errors of immunity demystified. So the outline of the presentation is that I will be talking briefly about the history of inborn errors of immunity as they are now called, and previously they were known as primary immunodeficiency diseases, their clinical manifestations. How do we go about investigating an inborn error of immunity? What is a tiered approach for laboratory testing? And then I'll be also talking about utilization of high throughput technologies in the diagnosis of these diseases, mainly flow cytometry and next generation sequencing, and also briefly about prenatal diagnosis. So what are PIDs? So PIDs are basically genetic diseases of immunity, human immunity, where there are single gene defects or monogenic defects in different genes which encode for different proteins of the immune system, and they involve both adaptive and innate immunity. And one of the very good definitions was given by Professor Robert Good, who was a pioneer and a legendary in the field of inborn errors of immunity. And he described these disorders as experiments of nature and the greatest teachers of modern immunology. And more than 450 such genetic disorders have now been described. So this is a newspaper cutting from 2007, where at the World Immunology Day, there was a meeting was held here at PGI. And at that time, there were only a few handful of patients who were diagnosed with primary immunodeficiency diseases. And the title of the newspaper article was that most immunodeficiencies diseases go unnoticed. So briefly about the early years or the early history of PIDs. Although the first description of PIDs is credited to Ogden C. Bruton, who described A-gamma-globulinemia in a young boy who suffered from recurrent pneumococcal infections, perhaps the first description of a PID was by W. Schulz from Germany, where he described necrotizing pharyngeal ulcers in an adult patient with severe neutropenia, which he describes as agranulocytose in German. This was an article in German. Then in 1926, there was a first description of ataxia telangiectasia, where predominantly the telangiectasia and the neurological manifestations were described. Then in 1937, Alfred Wiskott, who was also German, he described a familial form of thrombocytopenia in two families with young boys who presented with thrombocytopenia. And he described this as a familial form of Warburg-Verholfi, which was at that time the idiopathic thrombocytopenia. So he could identify these families, and he distinguished it from the common idiopathic thrombocytopenia and called it familial form of this idiopathic thrombocytopenia. This was way back in 1937. Of course, the gene associated with Wiskott-Aldrich syndrome and the other manifestations were described later. Then in 1941, almost 15 years after ataxia telangiectasia was described, Madame Louis Barre from France again described the different clinical manifestations of ataxia telangiectasia, including the cerebellar symptoms that these children have. In 1950, two Swiss pathologists described two infants with severe lymphopenia and disseminated candidal infection, which they called essential lymphocytophysis. So this is essential lymphocytopenia. They attributed this lymphocytopenia to the disseminated candidal infection, which was not true. And then, as I said, in 1952, Ogden Bruton described this A-gamma-globulinemia. And he is also credited with the therapy, because what he did was, at that time, by electrophoresis, the gamma-globulin fraction had already been described. And so he gave subcutaneous immunoglobulin to this child, and he showed that these symptoms could be resolved by giving subcutaneous immunoglobulin, the gamma fraction. In 1954, Janeway's group described what was different from the previously described cases was that these children had hypergammaglobulinemia instead of hypogammaglobulinemia, and they had severe recurrent chronic non-specific infections. This was in 1954. So this was perhaps the first descriptions of chronic granulomatous disease, because as you know, chronic granulomatous disease is associated with hypergammaglobulinemia. And then 1959, again there is a description of a few cases of chronic granulomatous disease. And at that time, this disease was called as fatal granulomatous disease of childhood, where because no treatment was available at that point of time. So how do we classify, since this is a very large group and heterogeneous group of disorders, how do we classify these disorders? So initially the WHO classified in 1972. The first classification was in 1972, but then the International Union of Immunology, the IUIS, had a special classification committee which updates this classification every 2 years. So the latest update was in 2022, where these experts from different, all across the globe, they met and then they classified these disorders. And the 2024 update is due. So this is another article where they, this provides actually algorithms for the classification of these disorders. So these two publications are very important if you want to go through what are the disorders about inborn errors of immunity. So as you can see from the figure here, that in the early 80s, there were only a few cases, less than probably 10 cases which are described. And then from the 2010, there has been an exponential increase in the number of PIDs that have been described. And this is largely because of the available of genetic technologies where you can sequence the exome or the whole genome of an individual very fast because of what is known as next generation sequencing technology, where you can sequence multiple genes, the entire exome, that is a coding region, or the entire genome of an individual in a day, or maybe 3 or 4 individuals in a day. The capacity is increasing. And the other table here, the bar graph here shows that even within the 2 years, that 19 to 2022, in different categories of these disorders, the red bars indicate the new disorders that have been described. So every year in that list, you have got 30, 40 new disorders which have been added. So the growth of these disorders is exponential. So what are the different categories of PIDs or IAIs in the 2022 update? So the first category they have described is immunodeficiency affecting cellular and humoral immunity. So in these disorders, the defect is very severe, and the affected children, they will have the both arms of immunity, the cellular and the humoral immunity will be affected. And the prototypic disorder in this is severe combined immunodeficiency. Then you have got the second category is combined immunodeficiency with associated or syndromic features. Here there is a combined defect, but then there are certain other features. It could be facial dysmorphism, it could be some other syndromes. So in these category, you have got disorders like Wiskott-Aldrich syndrome and ataxia-telangiectasia. The third category, which is the most common disorders which are encountered worldwide, are predominantly antibody deficiencies. And in this category, the prototypic disorder is X-linked agammaglobulinemia, which affects boys. The fourth category is the diseases of immune dysregulation, in which you have got disorders like familial HLH, autoimmune lymphoproliferative syndrome. The fifth category is congenital defects of phagocytic number or function. And in this, the disorders associated with the defects in number are the different neutropenias, the severe congenital neutropenia, and the disorders affecting function are chronic granulomatous disease, where there's a defect in the oxidative burst, or the leukocyte adhesion deficiency, where there is a defect in the leukocyte adhesion and egress from circulation to sites of infection. The sixth category is defects in intrinsic and innate immunity, where the prototypic disorder is Mendelian susceptibility to mycobacterial diseases. And in the last decade, there has been an exponential growth. There are now 50 to 60 disorders in the category of autoinflammatory diseases, where there are usually gain of function mutations, where the patients have elevated inflammatory markers in the absence of infections. So they present with severe inflammatory manifestations. However, this is in absence of infections because the immune system is in overdrive. Then we have got other disorders which are known as complement deficiencies. And the complement deficiencies, you've got complement system itself has got both, like you've got a classical pathway, alternative pathway. And in the classical pathway, the early complement components are associated with the susceptibility to autoimmune manifestations, mainly lupus. Late complement deficiency is associated with Neisseria infections. And then the alternative pathway and the regulatory defects are associated with genetic defects of atypical HUS. So the complement deficiency is also in this. And then perhaps in 2013, I don't remember off my head, bone marrow failure syndromes have also been included in this category. And the fifth category is very interesting. It is known as phenocopies of inborn errors of immunity. In this, the disorder are not associated with genetic defects. So here there are actually autoantibodies to different cytokines, or there are somatic mutations which result in. So this is a phenocopy of an inborn error because there is no germline defect in a particular gene. So either there are somatic mutations or there are autoantibodies. So what are the clinical manifestations of IEIs or primary immunodeficiency diseases? So infections, of course, are the most common manifestation, but it's important to realize that immune system works in a balance. So if you have defects in certain pathways, you can result in autoimmunity, you could have malignancy, or you could have autoinflammation. And what was missing here was atopy or allergy. So even a category of disorders known as primary atopic disorders have now been described. There are, I think, 30 to 40 disorders in this category where a single gene defect leads to severe atopic manifestations. So, of course, infections are the commonest manifestations, and therefore these disorders were earlier known as primary immunodeficiencies. But from the 2019 or 15 classification, the terminology was changed to inborn errors of immunity because infections are not the only manifestations. Some children or adults may present only with autoimmunity with hardly any infectious episodes, or they can have autoinflammation, as I said, where there is hyperinflammation in the absence of infections, or the defects can also predispose them to malignancy. For example, in ataxia telangiectasia, where there is a defect in the ATM protein which is involved in double-stranded DNA breaks. So those children have a high susceptibility to develop malignancies, especially hematological malignancies like lymphoma. And even the carriers, the heterozygous carriers of ataxia telangiectasia are at increased risk for these malignancies. And female carriers of ataxia are at a risk of breast cancer. So, and there are other defects which are involved in DNA repair, which are also associated with increased risk to malignancies. And atopies are also associated with some inborn errors. So, how do we identify a given IEI or PID clinically? So there are three handles mainly, clinically, not without a lab support. So that is age at onset, types of organisms, and family history. So this is a very simplistic approach to the age of onset. So there are some disorders like severe combined immunodeficiency which will present very early. They will present in infancy, or they can present even in the first or second months of life because there is a severe defect in T cells and also B cells, because B cell require T cell help for their whole function. You could have Digeorge syndrome, which presents in very early. You could have other disorders of thymic defects which can present here. Antibody deficiencies like your X-linked agammaglobulinemia or autosomal recessive hypogammaglobulinemia, they typically present after 6 months of age. And this is because that the maternal immunoglobulins which are transferred to the fetus transplacentally, they protect the infant from infections till 6 months. Although this period is variable because the catabolism of the maternal immunoglobulin which has been transferred to the fetus is variable in each fetus. That depends upon the IgG catabolism, which is variable in every individual. So 6 months is not a cutoff. You could have infants who present at 4 months, or you could have infants who present even at as late as 18 months. And it also will depend on the genetic defects. Discott-Aldrich, which also present at 6 months. Phagocytic disorders like CGD can present, usually present with 6 months to 5 years, but this is quite variable. So certain infants who have got a very severe mutation may present in infancy. And if there are what are known as hypomorphic mutations where there is still some protein left, they even present at adulthood. And they can present not only with infections, they can present with even symptoms like inflammatory bowel disease. Then a common variable immunodeficiency is bimodal disease, where the most commonly affected individuals are adults in the second and third decades, but it also affects young children. But in children, as per the diagnostic criteria, the onset of the disease should be after 4 years of age, and usually they present in between 5 to 10 years of age. And complement deficiency and specific autoantibody deficiency also presented after 5 years. So, depending on the age at onset, you can predict which of these disorders it would be. Even LAD would present in the first few weeks or months, but it is quite variable depending upon what type of mutation is there. If it's a severe mutation, it will present early. If it is a mutation which is hypomorphic and there is still some functional protein which is left, it would be later. So, these are useful pointers, but in a given case, it will be highly variable. Family history is very important. So there are a lot of disorders which present with a X-linked recessive inheritance. So these are like severe combined immunodeficiency, the common gamma chain defect because of a defect in IL-2RG, X-linked agammaglobulinemia, which is because of a defect on BTK gene. Then the X-linked form of chronic granulomatous disease, which is caused by a mutation in the CYBB gene. The X-linked form of hyper-IgM syndrome, which is because of a 40 ligand defect. Wiskott-Aldrich, as I've already said, is also another X-linked disease, which is caused by the defect in the VAS gene. And then you've got others like less common ones like X-linked lymphoproliferative syndrome, the X-Men syndrome, and one of the complement deficiency, the properdin deficiency, also presents in an X-linked recessive manner. There are other disorders, there are other modes of inheritance. So autosomal dominant disorders, you've got chronic granulomatous disease where there are autosomal recessive forms of manifestations. Ataxia telangiectasia is an autosomal recessive disorder. And there are hyper-IgM syndromes which present in autosomal recessive mode. That the common ones are the CD40 defect or the AICDA, the activation-induced cytidine deaminase, or these are the disorders. And there are other disorders of presenting with the phenotype of severe combined immunodeficiency which are inherited in a autosomal recessive manner. Autosomal dominant disorders, the common example is the hyper-IgM syndrome, which is caused by a loss of function in the STAT3 gene, hereditary angioneurotic edema, which is caused by the autosomal heterozygous variant in the SERPIN G1 gene. And then you've got others like STAT1 gain of function, the active APDS, and the CTLA4 deficiency. So these are some examples of autosomal dominant disorders. So what are the different pathogens which are commonly seen in different disorders? So if it is a combined defect, like because of a defect in T cells, you have got kind of a full house pattern. You will have bacterial infections, you've got viral, you will have parasitic, fungal, and mycobacterial. Whereas B cells, you have usually bacterial infections, and these bacterial infections are usually because of encapsulated bacteria like Haemophilus influenzae or Streptococcus pneumoniae. And they are also predisposed to enteroviral infections because mucosal immunity is involved in antibody defects. So they will present with enteroviral and they will present with encapsulated organisms. If there is a pure NK cell defects, of which there are a few examples, they will predominantly present with viral infections. If there is a defect in the polymorphonuclear neutrophils, the infections will be predominantly bacterial and fungal. And complement deficiency is similar to your antibody deficiencies. They commonly predispose to infections with encapsulated extracellular encapsulated bacteria. However, the late complement pathway like C5 to C9 or C10, they would be associated with specifically to Neisseria infections. And mononuclear cell defects, like I said, MSMD and all, they would be predisposed to fungal and mycobacterial. So this is also a generalized or a broad classification. As you can see, there are overlaps. And in a given case, you might have to investigate broadly to rule out disorders. But these are soft clues or handles when you are encountered with a child with IEI. And this is also important to highlight that there is a reciprocal relationship between microbial virulence and PIDs. So if you have an infection with a vaccine associated, because vaccines are live attenuated, and if a child has presented with a disseminated BCGosis, that is a time when there should be a red flag sign that why has a child with a healthy immune system presenting with a severe infection with a vaccine strain of an organism, or a microbe of low virulence causing a disseminated disease. So the likelihood of inborn error of immunity is very high when the infection is because of a vaccine strain or because of a microbe of low virulence, which will normally not cause severe infection in a immunocompetent host. So this is also very important, and vaccine associated symptoms should be taken very seriously. So how do we go about investigating an inborn error of immunity in the lab? So there are two approaches depending on which setting you are working in or what are the resources available. So you can start with the very basic investigations at the bottom of this pyramid. You can do a complete blood count. You can do immunoglobulins. You could do a simple nitroblue tetrazolium dye reduction test. Then move on to flow cytometry, do some enzyme studies, cytokine and cytokine receptor studies. And then finally, when you have a clue about which pathway or which genes are we talking about, you could go for a targeted gene sequencing either by Sanger or by a targeted gene panel. However, since now genetic sequencing is readily available, you could directly go to gene sequencing first. And depending upon the results of the gene sequencing, we can then do functional studies like flow cytometry, enzyme studies, cytokine receptors. And then if you have got a novel gene or you have got a novel variant, you could try cell culture or animal or gene knockouts to validate the function of that particular variant or a novel gene. So these are two approaches. We generally follow this one because it is critical to have some functional data and some basic information about the case before proceeding to genetic sequencing. And even when you do genetic sequencing, you have to follow up with these tests. So the approach entirely depends upon the resources available and the kind of setting that you're working in. And this also shows the same pattern, like you could directly go to exome, or you could first do a functional analysis and then go to an exome. However, as I said, a tiered approach is useful, where you do the basic investigation first, so a complete blood count including differential counts, quantitative immunoglobulins. You could do a nitroblue tetrazolium dye reduction test, move on to a lymphocyte subset analysis. You could do an oxidative burst by flow cytometry, and then you could do some functional tests for T cell function, like lymphocyte proliferation using mitogen or antigen. And then there are some other specialized tests. You could measure the enzymes like ADA1, ADA2. You could do a functional testing for the complement, the CH50 for the classical pathway, AH50 for the alternative complement pathway. You could assess cell surface or intracellular molecules by flow cytometry or Western blot. And then finally, you could proceed to genetic studies, which are important and have their place in the diagnosis of these disorders. And this could be in the form of a Sanger sequencing, where you know that one particular variant is associated with most, or the gene is small. Or if you have a clue about a particular syndromic diagnosis, you could do a gene panel. Whereas when after immunological investigations, your differential is broad, you could go for an exome. And in some situations, although not clinically used now, you could also do a genome sequencing. So this is a table from the Jeffrey Model Foundation, which essentially shows the same approach, you should approach in a stepwise or tiered manner. So I'll first talk briefly about the simple investigations which are readily available everywhere. But a complete blood count should be taken very seriously, and you should calculate all counts and then see, because just brushing through the CBC is not enough. So absolute lymphocyte count is very important, and lymphopenia is associated with combined defects, and the most common would be a severe combined immunodeficiency. So any infant with a lymphocyte count less than 2,500 or 3,000 should be investigated for a severe combined immunodeficiency. And lymphopenia can also be associated with other combined defects. In contrast, there are IEIs which are associated with lymphocytosis, and these categories include the diseases of immune dysregulation, where a IEI is associated with a lymphoproliferation. This could be in the periphery or in the blood. Omen's syndrome is a subtype or a variant of SCID, where you've got oligoclonal proliferation of clone of T cells, and this is also associated with lymphocytosis. Absolute neutrophil count is also very important, and it is often ignored. However, severe neutropenia is seen in severe congenital neutropenia, but there are certain antibody defects which are also associated with neutropenia as an autoimmune manifestation. This is very important to understand. So, X-linked hyper IgM syndrome is one such. It is now classified as a combined defect, not as an antibody defect. These children have 25 to 30% of them may have neutropenia at presentation. X-linked agammaglobulinemia is also associated with neutropenia, and at the bottom there are other autoimmune disorders like common variable immunodeficiency, which can associate it with neutropenia. Neutrophilia, on the other hand, is associated with other disorders. So, leukocyte adhesion deficiency is associated with neutrophilic leukocytosis, because the neutrophils are trapped in the circulation because there is a defect in the adhesion of these neutrophils to the endothelium, and subsequently they egress to the circulation. So, when there is a defect there, the neutrophils are being produced in response to infection, but they are not able to leave the circulation to sites of infection. So they will keep on accumulating in the circulation, and you have counts like 50,000 to 1 lakh in a child, and you could suspect that it's a leukomyoid reaction to infection, but it could also be a leukocyte adhesion defect. And chronic granulomatous disease is also a functional defect in the neutrophils. So to compensate for the functional loss, more neutrophils are produced, and CGD is also one of the PIDs which is associated with neutrophilia. Thrombocytopenia, as I said, one of the disorders, Wiskott-Aldrich syndrome, is associated with thrombocytopenia, and it also has small platelets, and autoimmune, as an autoimmune manifestation, it can be seen in other disorders like CVID. There's a whole category of disorders which I told, primary atopic disorders, and these are associated with eosinophilia. So, in addition to a CBC, a peripheral smear examination is also very important. And this is a case of Shinya-Higashi syndrome, where you can see these giant inclusions in the cytoplasm. And this is a microplatelet in a child with Wiskott-Aldrich syndrome. Howell jelly bodies are seen in patients with your asplenia. There is a congenital form of asplenia because of a defect in RPSA gene, where you will see this Howell jelly bodies even in a newborn. Then you've got myelocathexis, which is a characteristic feature of WHIM syndrome, which is warts, hypogammaglobulinemia, infections, and myelocathexis. So this WHIM syndrome is characteristically associated with myelocathexis. So this is one of our case of a specific granule deficiency, where the child presented with, there were two siblings who presented with episodic neutropenia along with severe infections leading to scar formation. They had severe skin infections which led to disfiguring scars. And as you can see here, the neutrophil has got abnormal morphology. The lobes are not normal, they are hypolobular, and the cytoplasm is less granule. The granules are missing in this. The cytoplasm is less granular, and then again here you've got an abnormal lobation. Here you've got another abnormal lobation. So specific granule deficiency has also got types, so type 1 and type 2. But this again, if you are careful, you can probably, and you know the clinical history, you could probably pick up on a peripheral smear. The dysplastic megakaryocytes on a bone marrow, like this, you've got like you've got small megakaryocytes, you've got the dispersion of the nuclei. This is CD61. So this abnormal or dysplastic megakaryocytes is usually seen in germline GATA2 defect. The somatic GATA2 defects are associated with malignancy, but you have a germline defect where you've got a dysplastic megakaryocyte. And then there's another syndrome which is known as a Vexer syndrome, which is caused by a somatic mutation. And here you've got abnormal vacuoles in both erythroid and myeloid precursors. So these you can pick up on peripheral smear examination or a careful bone marrow examination. Another important clue is a hair shaft microscopy. And here you see two examples, one of Shinya-Higashi syndrome. So in a normal hair, you will have medulla and the cortex, and there will be uniform pigmentation of the cortex. Whereas in a child with Shinya-Higashi, you've got these abnormal pigment clumps, which are regular in size and regularly distributed. Whereas in Griscelli syndrome, you've got there's a pigmentation in the hair shafts are hypopigmented, and you've got abnormal clumps of pigment which are irregularly placed, and they are irregular in size. So these are the two forms that we commonly encounter, and they are associated. They could be associated with HLH in the accelerated phase. This is again, and this typical silvery gray hair that you see, and this is again a child with Griscelli syndrome. That this is a published case, and again you see one granule is so small, the other is so big, and they are irregularly placed. So this is a differentiation between Shinya-Higashi syndrome and Griscelli. And in Shinya-Higashi, in addition to this abnormal hair shaft microscopy, you also have abnormal inclusions in the neutrophils, commonly in the neutrophils, but you could see them in the lymphocytes as well. So what are the other tests that we do perform in these cases? So one of them is nephrometry, and by nephrometry we estimate the immunoglobulins, the IgG, the different isotypes of immunoglobulin, the IgG, AM. We can also estimate IgE. We can estimate the acute phase reactants like CRP. We can also do subclass estimation, IgG1, G2, G3, G4. And from after that, we proceed to flow cytometry, which is a very important tool in the diagnosis of disorders. We could do a few ELISAs or suspension bead arrays. And finally, we proceed to a genetic diagnosis by Sanger or next generation sequencing. So I'll just be talking briefly about flow cytometry. So a flow cytometer has three components. So one of them is fluidics. So the another is optics. So what you do is that you make a single cell suspension. In flow cytometry, the cells have to move in a single file, because your laser is going to interrogate single cells. You don't need clumped cells, you need single cells. So blood, your cells are present singly, so that's not a problem. But if you have a FNA sample, if you want to do flow cytometry on a biopsy sample, you have to homogenize to get single cells. You have to remove the collagenate, you have to add a collagenase treatment. But blood, since the cells in a fluid state and they are single, that's not an issue. So the fluidics, most of the flow cytometers are what is known as hydrodynamic focusing, where they align these cells in a single file. And then there is a laser which interrogates these cells, passing cells. And when the laser strikes this cell, there is light scattering. So what is captured is a forward scatter. It is in the same direction as the direction of the laser. Then there is side scatter, which is at 90 degrees. And then you could label your cells with different fluorochromes and then detect it by different detectors. So basically, you have got a fluidics where your cells have to move in a single file. You have got an optics. This is shown as one laser, but you could have array of lasers. You could have 3, 4, 5, depending on how many parameters you want to do. And then light scattered is collected by this different detectors. You've got what are known as band pass filters and all. I did not go to details of that. And then when the light is detected, it is converted into the electronics converts into a signal, and then you get a raw data which you have to analyze. So analysis is done by softwares. I'll not go into details, but basically this is the basic principle of flow cytometry. So what is the use of flow cytometry in the evaluation of IEIs or PID? It could evaluate altered lymphocyte populations. It can detect defects in cell surface protein expression, intracellular protein expression. You could detect even functional defects with flow cytometry. It can be used to for a functional validation of novel variants. It has a promise of redeeming you from the woes of woes, variants of undetermined significance, because more and more with genetic testing you get, when you get a report that says this is a VUS or VOUS, whichever they call it, and then you're left with nothing. What to do? How do you counsel whether this variant is responsible for the clinical phenotype or not? And it could also be used for testing for post-transplantation chimerism. So I'll briefly take examples from some of these cases. Can anyone tell who this child is? The bubble boy? Nahi pata. NASA created a special suit for him because this child had an elder brother who was born with SCID, and when this child was born, they put him in a bubble, and he survived for quite a long time, till I think 10 or 12. And then when he was transplanted, he had a EBV-associated disorder, after which he died. So severe combined immunodeficiency disorders again come in different flavors, as I said. And so how do we go about doing a flow cytometry? You use what are known as markers, CD markers, cluster of differentiation markers. So the first marker that you see here on this panel, the upper panel shows the control, the lower panel is the patient, and you used, this is actually side scatter, and this is CD45. What is CD45? Does it say that? No, leukocyte common antigen, LCA. So it is expressed on all leukocytes, but this is neutrophil. You don't see a monocyte cluster here, but the highest expression of this CD45 or the leukocyte common antigen in the leukocytes is on lymphocytes. So you got this CD45, you gated it, and then you look at different markers. CD3 is a marker for T cells. As you can see here, the T cells are almost like 80%. This is CD19, which is B cell, 10%, and you've got CD56 NK cell, which is normal. And here when you gate, you see that there is CD45, CD19 is absent, and you've got T cells. So could this still be SCID? I mean, you've got NK cells. So this is T plus. This is not a very usual form. So it could still be SCID because there would be, what you have to do now is to look at the naive and the memory T cells. So this is another example which is more simple. So again, you've got this is the neutrophil spindle. This is based on side scatter and 45. This is your monocytes. These are lymphocytes. You've gated the lymphocytes. And when you see here, there are no T cells, 4%. And your B cells are normal, and NK cells are also 10%. So this is a T minus, B plus, NK plus SCID. Whereas in the lower panel here, you see again you've gated the lymphocytes. So CD45 is highest on your lymphocytes, and side scatter that determines the granularity of a cell. So the neutrophils have got abundant cytoplasm, the cytoplasm is granular, and so you see higher side scatter in neutrophils, and the monocytes, they have more side scatter than lymphocytes but less than neutrophils. So the monocyte cluster is here. And again, when you gate and see, there are no T cells, there are no B cells. So this is a T minus, B minus, NK plus SCID. So this confirms the diagnosis of SCID, but it also helps in determining the genetic etiology. For example, this T minus, B minus, NK plus SCID is associated commonly with RAG defects. RAG1 and RAG2, it could be associated with Artemis. So based on the immunophenotype, you could guess the genetic etiology of that particular case. So if you don't have an NGS, probably you can do a Sanger for those genes. And again, after you've done this panel, what you can do is you can move to a cell surface marker. So this was a child with T minus, B plus, NK plus SCID. So only the T cells were absent. And when we again get this is actually forward scatter and side scatter, so don't get confused. This is not 45, this is forward scatter. So in the forward scatter, the lymphocytes will be they have got the smallest size and the smallest, and they are less granular, so they will fall here. So again, you look for CD127. What is CD127? It's the IL-7 receptor. So as you can see in the control, there's a normal expression. In the patient, there's absent infection. So even without doing a genetic testing, you could say that this child with severe combined immunodeficiency has a disorder because of defect in IL-7 gene, IL-7 receptor gene. And you could also stain for common gamma chain, which is associated with T minus, B plus, NK plus KIT. And in this patient, you've got decreased expression compared to control. So even without flow cytometry, even without genetic testing, you can diagnose based on flow cytometry. And you could also do a functional test. So this again, what you do here is you stimulate the cells with your IL-2, because the defect is the IL-2-RG gene, and then you look at downstream molecules. So in this child with IL-2-RG defect, there is no expression of phosphorylated STAT5, because downstream of this, through JAK-STAT, P-STAT will be increased. So when there is a defect in that receptor, the downstream signaling will be impaired. And for Omenn syndrome, you can do HLA-DR. So HLA-DR is a MSC class 2 molecule which is expressed on antigen-presenting cells. But in abnormal situations, it can also be present on T cells. So in this case, you see 85% of your T cells are showing HLA-DR expression, which is highly abnormal. And this is seen in cases of Omenn syndrome. This can also be seen in HLH as well, because in HLH also the T cells are activated. In combined immunodeficiency with associated or syndromic features, so this is a child with Wiskott-Aldrich syndrome. So you've gated the lymphocytes. These are the monocytes. These are the neutrophils. And as you can see from the overlay here, there is a nice expression of VAS protein on lymphocytes in this control. In the patient, it is entirely absent. And in the lowermost panel, you see there's a mother. And in mother, you see 2 peaks. So why are these 2 peaks present in the female? In females, there are 2 X chromosomes, and none of them goes under random inactivation, lionization. So female carriers, if you have 2 peaks, then you can know that. So these were the ones which don't express, and these are the ones which express. So in female carriers of X-linked diseases, where you have a flow cytometry-based test available, it is very useful to test for the mothers. So even without doing a genetic sequencing, you could still say that this child has a Wiskott-Aldrich, but then the mother is also a carrier, because she's showing she's showing a bimodal expression of this protein. Similarly for BTK protein also, if you want to test whether the mother is a carrier, you can do a flow cytometry. However, in 25 to 30% of the cases, it could be de novo. And this is again from one of the cases of Wiskott, and you see that this is a control. This is a patient pre-bone marrow transplantation. And after bone marrow transplantation, there is a nice shift indicating that engraftment and chimerism is optimal. In primary, predominant autoantibody deficiencies, this is a case of XLA, and the child presented at 2 years of age with recurrent infections, mainly respiratory tract infections, some GI infections. And when the immunoglobulins were entirely absent, pan-hypogammaglobulinemia, and again when we did the flow cytometry, you see B cells are not present. T cells are present. T cells are, it is 87%, NK cells are 10%. So you add this up, it will be something like 98%, and your B cells are entirely absent. So this tells you that in a boy who has no immunoglobulins, B cells are absent. The first thing which comes to your mind is X-linked agammaglobulinemia. So can we do something before gene sequencing? So we can estimate the BTK protein. So this is what I was talking about. So BTK protein is present on B cells, but B cells are not present in the patient. So what do we do? So it is also expressed on monocytes. So this is CD14, which is expressed on monocytes. Upper panel shows the control, the lower panel shows the patient. So you gating is just drawing an artificial gate And what it does is that it tells you only about this population. So you want to know the BTK expression only here. So then you're gating this population, then looking at that. When you gate it, it's just that you want to analyze this population and see what is happening there. So you gated the monocytes in the control and you see there is an expression of BTK protein there, whereas in the patient, this is the overlay, there's hardly any expression. So even before doing a gene sequencing, you could still say that this boy who has absent immunoglobulins, suffering from recurrent infections with no B cells, pan-hypogammaglobulinemia, is a case of X-linked agammaglobulinemia. So the next disorder is this is a mononuclear cells showing phagocytosis. So this category is diseases of immune dysregulation. And in this, you've got different forms of familial HLH. And what you can do by flow cytometry is you can look at the expression of perforin. So these are like cytolytic proteins which are present in NK cells and also cytotoxic T cells. And what they do is they kill the target cells. So this is the upper panel is the control. So you gated CD56 positive, CD3 negative. The positive ones are here. And this is CD56. So you have gated the NK cells and looked at the expression of perforin. The upper panel control again, and in the patient, there's hardly any expression of perforin. So this again indicates that this is a familial HLH because of a defect in perforin. This is the most common effect of HLH which is encountered. However, it is very important to be cautious because even in secondary forms of HLH, there could be some decrease in the perforin, but entirely absent perforin expression, especially in a young child, denotes that it's more likely a familial cause rather than a secondary cause. The other assay which we do from other forms of HLH is a granule release assay. And in this, again, you have to get the NK cells and then look at the CD107A. So what is CD107A? It is a lysosomal membrane-associated protein. It is present on the lysosomal membrane. And inside the lysosomes, you've got granzyme and perforin. And when these NK cells have encountered a target cell which they have to lyse, they have to kill, what happens is that the granules, the lysosomal lysosomes, they will fuse with the cell membrane and they will release the granules. And when that happens, that CD107A will be expressed on the surface. So you have to activate. So in this case, this is not whole blood. They have separated PBMCs. PBMCs are peripheral blood mononuclear cells stimulated with the stimulant. You could use PMA, you could use PHA, you could use other stimulants, and then looked at the 107A expression. So this was unstimulated and this was stimulated. So upon stimulation, you see here this is markedly reduced compared to the control. So this indicates that in this particular case, there is a defect in granule release. So this could happen in disorders other than the perforin defects. It could happen in Griscelli, it could happen Griscelli type 2, it could happen in Shiryak Higashi, it could happen in syntaxin defect, monk defects. So these are the disorders which are familial HLH which are associated with defects in granule release. The next category is congenital defects of phagocyte number or function, and in this I've taken CGD as a prototypic example. So CGD, as you can see, is a defect in the NADPH oxidase complex, and it is a heterogeneous disease. The phenotype is same, but the genetics is heterogeneous. So you've got an X-linked form because of the CYBB gene. Then you've got autosomal recessive forms. The most common autosomal recessive is P47. Then you've got NCF2. NCF2, for some reasons, is not very common in South India. It's more common in North India. CYBA is more common in South India, not in North India. And then you've got a very rare form, which is NCF4, which we haven't encountered any case. And then there is another new one, which is described, which is known as EROS or CYBC1. This also has been reported, one or two cases have been reported from South India. So this is a one phenotype CGD, but there are numerous defects. And what we can do by flow cytometry to test for this? So again, we do a functional test. So the dihydrorhodamine test for CGD is a functional assessment of NADPH oxidase activity in the neutrophils. So when you do a functional test, it is very important that your neutrophils should be fresh. Ideally, it should be within 2 hours of draw or maximum 6. You can do up to 24, but then you'll have to have a control to know that what is you're seeing in your sample is actually not because of storage artifact, and it is actually a true indicator of the function. So whenever there's a functional test, it is very important that you don't do it on a stored sample. It has to be a fresh sample. So for the DHR, again, this is forward side scatter, and you see the neutrophils, which have got the highest forward scatter because they are largest in size in the peripheral blood, and they have got more granular cytoplasm. So this is a neutrophil. This is the patient. I'm sorry, he is missing here. And then again, this is a mother. So you see in the so dihydrorhodamine is a non-fluorescent dye. When you stimulate it with PMA, any stimulant, what it does, because of the neutrophil oxidase activities, it is converted to rhodamine, which is a fluorescent dye. So this is unstimulated, meaning you have not added a stimulant. And when you add PMA, porvol myristate acetate, which is a stimulant, there is a shift because your dihydrorhodamine has now been converted to rhodamine. But in the patient, you see, because there is no NADPH oxidase activity, there is no shift. So you know that this is CGD. Can you do more? Yes, you can. You've got a mother here. You gated the neutrophils and you saw 2 peaks. So even without doing a genetic testing, you know this is X-linked CGD since there is a mother who has 2 peaks. So the next group of disorders is defects in intrinsic and innate immunity. And here you've got the prototypic disorders like Mendelian susceptibility to mycobacterial diseases. And here again, you can look in the PBMCs. So again, PBMCs are separated. How do you separate PBMCs? Does anyone know? So it is by density grade centrifugation. Use something known as Ficol hypake, which is patented because each of your cell in the peripheral blood will have a different density. And based on that, you get a ring of PBMCs when you do a density grade centrifugation. So again, you've gated the PBMCs, you looked at the T cells, the upper panel control, and you see upon stimulation again. So this is actually for 3 days. This stimulation is for 3 days with PHA. And you see in the patient, in the control, there is a nice shift. In the patient, there is no shift. So this is IL-12 receptor beta defect. So this again has been picked up here. So in the control, it is normal. The shift is normal. In the patient, it is absent. So you know that this particular patient with a suspected Mendelian susceptibility to mycobacterial disease has a defect in IL-12 receptor beta 1, which is the most common defect in the patients with MSMD. And you can do a functional test also, because in some patients the expression might be normal. So this is another important thing. Just the expression of a protein doesn't indicate that there is no disease. Absence indicates a disease, but the present doesn't, because it could still be an abnormal protein. And then you have to do a functional test. So again, here you stimulate your cells with recombinant IL-12 and look for the downstream signaling P-stat. So in the stimulated it is normal, in the patient it is abnormal. So P-stat is downstream of IL-12 cytokine. And so if the receptor is abnormal, the phosphorylation will not occur. So your P-stat 4 the expression is normal in the control, in the patient is absent. So another one is IFN gamma R1. This is another form of MSMD. And in the autosomal partial dominant, there is an increased expression of the IFN gamma R1, in contrast to the autosomal recessive, where there is a marked in. So I'll just briefly move about to genetic diagnosis. So the genetic diagnosis is also important because it provides a definitive diagnosis, at times resolving a diagnostic odyssey. It has got implications for targeted or personalized medicine. It can describe unusual phenotypes of known diseases, new genes for previously described phenotypes, helps in advocacy of patients, and it's also important for genetic counseling and antenatal diagnosis. What are the different methods? You've got Sanger sequencing, you've got massively parallel sequencing or next generation sequencing. It again comes in 3 flavors: targeted gene panels, exome sequencing, and whole genome sequencing. You could resort to a RNA-seq in certain special situations. Although copy number variations are not the majority of the genetic defects in patients, but in some cases you do need to look for copy number variations. So the timeline of DNA sequencing, the first one and still the gold standard is the Sanger sequencing. It was described by Frederick Sanger. But initially it was your nucleotides were tagged with radionucleotides, and it was very cumbersome to do. In the 1980s, automated DNA sequencing with nucleotides tagged to fluorophores became available, which made life easy. And now from the 2005 or 2010, you've got next generation sequencing, which is a very rapid, high throughput method to do DNA sequencing. So this again is about, I think you already had a class on NGS probably. I think I'll just skip run out of time. So in Sanger sequencing, there are 2 steps. You have got an amplification PCR and a sequencing PCR. In amplification PCR, you use DNA polymerase. This is typically a tag polymerase. You use primers, a forward primer and a reverse primer, which is for a particular target, in this case a particular exon of a gene. And the second is the sequencing PCR, where you use a mix of 2 kinds of nucleotides, dideoxy and deoxy. In the amplification PCR, you only use deoxy. Here you use 2 because wherever a dideoxy is incorporated, the chain will terminate. So it is also known as chain termination method. And then all your fragments, you will have fragments of different size. They are resolved with capillary electrophoresis. And then you get a read, which is known as an electropherogram or a chromatogram. So these are 2 examples. This is a child with HLH, where there are 2 variants. So you can see there are heterozygous peak, one coming from the father, one coming from the mother. So this is a compound heterozygous variant in the perforin gene. This is a child with Blau syndrome, and this is the autosomal dominant disease. And again, you see heterozygous peaks. So in sequencing PCR, you only do strand by strand. You can sequence a forward strand once and then a reverse strand. You can't, you're not sequencing a single strand. Next generation sequencing, I think, has been done and not go into details. So these are some IGV snapshot. This is a child with X-linked agammaglobulinemia where there was a defect in the BTK gene. So these are known as what are reads. So this is a view from the IGV snapshot. And this is a child with GATA2 defect where you see a 10 nucleotide deletion. And this deletion is not present on all reads. This is heterozygous. So you see there are some reads where these nucleotides are present. So in a heterozygous, you will have 50 or, close to 50% of the reads which will show the defect, and the other 50 will be normal. And this is a child with ARCGD, autosomal recessive CD, where you've got no reads from NCF1 exon 2 because of a defect because of a pseudo gene which is present there. So pseudo genes are also a problem in sequencing because they will interfere with your sequencing, and you cannot design reliable primers for those particular regions. You'll either have to resort to things like gene scan or a long range PCR for pseudo genes. And when there's a large deletion, what do you see on a IGV snapshot? So there are no reads from these 3 exons. So either this could be a technical issue, or these particular exons are deleted in this patient. So if they are deleted, you don't get any reads from there. And then you can confirm this either by MLPA or by a other technique. This is a snapshot from a MLPA. I think I'll not go into details of this. So briefly about prenatal diagnosis. So usually we do by a CVS, which is done in the Department of Gynecology. This is a CVS sample. The adherent DNA clots are removed under a dissecting microscope. You do a DNA extraction, then do a VNTR analysis to rule out maternal contamination. You also do an amylogenin PCR in the case of X-linked diseases, because if it's an X-linked carrier, you will not proceed further. Then you do a PCR amplification using specific primer for that particular disease. You do a gel electrophoresis to confirm that you have a band, and then you do sequencing. So for an antenatal diagnosis or prenatal diagnosis, it is imperative that you have the genetic diagnosis in the index case. Without that, it is very difficult. So coming to the end, so IEIs or PIDs are like a jigsaw puzzle, and you have to fix up everything. So the history is very important. The medical history, the family history, what was the mode of inheritance, what were the infections, what was the age of onset, are there any other siblings who are affected with this disorder? And then, as I said, microorganism is important, age is important, and then you got the tests. Since I'm a pathologist, I've put test at the center. No offense. Thank you.